It's in my head. Do you have his bio? That's a very brief piece of paper. Hey, how are you? Thanks for coming. Oh, right. Which smart work? That's okay, folks, we'll get started. Before we start, just a reminder from Dr. Stadnik to put your credits and your for your CME in the portal. The deadline is Jan 31st. Is that right? Yeah. So this morning, I'm very pleased to introduce Dr. Parlow, who's one of our own. He was our chief resident, a superb chief resident, finished 18 months ago, and he's now doing a critical care fellowship. He's about to finish his first 18 months, and now he's going to London in England to do 6 months. You know, he was a superb chief resident, as I said. He's got very substantial research achievements, but in my opinion, his greatest achievement was his 2022 virtual Jeopardy rounds, which is, if you haven't watched it, is utter comic genius and really the highlight of his career so far. So, Simon.
All right. Thanks, everyone, for being here. And thanks for the introduction, Dr. Burney. So yeah, I've spent the past 18 months down the hall at the Ottawa Hospital, and I've just been gazing down the hall at this place, and I've been missing it, and it's great to be back. So thanks for having me. So today I'm going to talk about a variety of topics, all within the field of cardiogenic shock, and that's going to include some interesting research areas for future research that I see as important, and I'm also going to discuss some of the projects that our group has done here at the Ottawa Hospital. This is the outline, so I'll start with a brief introduction, go through medical therapy and cardiogenic shock and what we know about it. I'm going to talk again about some of these future areas of interest that I think are exciting. Talk a little bit about structural intervention and cardiogenic shock and some of the work that our structural team here at the Heart Institute has been doing. And then lastly, touch on some outcomes research. So starting with a brief introduction, and I will say one more thing, which is that I'm not going to speak about mechanical support or ECMO, which is a massive, enormous field, and it's just completely out of the scope of this presentation, even though it's an important area to discuss. So to start out with, as an introduction, cardiogenic shock is a state of organ hyperperfusion from cardiac dysfunction. That's typically the definition that we see in the literature, and I don't need to explain that to most of you. It's a very high-risk disease. Mortality can be up to 50%. We see that often. Typically, acute MI-related cardiogenic shock is in the high 40s up to 50% range. Typically, general cardiogenic shock around 40% in hospital mortality, and a little bit lower in some of the registry data, but it's certainly a very high-risk condition to have. Holger Thiel, who is one of the most prolific researchers in cardiogenic shock, he's in Germany. In 2019, he released this meta-analysis and review paper of all the trials and all the research that we have for acute MI-related cardiogenic shock. And this is everything we had in blue up until 2019. And as many of you know, for the past 25 years, there's actually only one positive trial. and that's the shock trial from 1999. And that's, again, for decades, one of the only pieces of randomized evidence that we had to guide management for these patients. So this was, again, in 1999, and patients with acute MI-related shock were randomized to receive revascularization early, plus medical therapy, or medical therapy alone. Actually, it wasn't the primary outcome, it was the 6-month outcome that was positive. And the medical therapy arm had a mortality of 63%, those that were revascularized 50%. And so this is an important trial because it told us that we need to revascularize patients with acute MI-related shock. And that was, again, the only positive trial until recently, and I'm not going to talk about this trial because it's been discussed at length, but until danger shock, which was Impella use in acute MI-related shock, again, that was the only other positive trial that we have to date. So I'm going to move on briefly to medical therapy in shock, and I'll start with vasopressors. I just want to make sure that everyone's up to date with the literature that guides vasopressor use. So of course, vasopressors are not very good for the heart. They increase afterload and things like that, but we need to use vasopressors in the critical care unit because people die when they're hypotensive. So we need to choose one of these, and for a while we didn't have evidence to decide which one of these vasopressors to use to support patients' blood pressure and perfusion in the cardiac ICU. So the SOAP-2 trial was really a landmark trial in terms of vasopressor choice for critically ill patients. There were 1,000 patients that were randomized to norepinephrine or dopamine. Dopamine was commonly used 15 years ago when this was done. And the trial overall was negative. In terms of the overall population, there was way more AFib in the dopamine group, way more AFib and arrhythmias and other things in the dopamine group. But they actually did a pre-specified subgroup analysis dividing the population by subtype of shock. And when you look really just at the cardiogenic shock population, of which there were 280 patients, there was a big benefit in terms of mortality with the use of norepinephrine. So from this, we took away that in cardiogenic shock, norepinephrine seems to be the vasopressor of choice over dopamine. The only pure cardiogenic shock trial comparing two vasopressor strategies was the Optima trial. It was small, and the reason it was small is because it was stopped early by the DSMB for ethical reasons. But they randomized patients to norepinephrine or epinephrine. The primary outcome was refractory shock, which is listed here, and you can, the short answer is it just means they got worse. And it was stopped after 57 patients because a large number of patients in the epinephrine group met this outcome of refractory shock. And again, we take this and we think it means that norepinephrine is probably better than epinephrine as a first-line vasopressor agent. And in Holger Thiel's paper in 2019, meta-analysis, he did combine the 3 RCTs that we have looking at vasopressor use in shock. And there's a statistically significant trend towards improved mortality with norepinephrine over dopamine or epinephrine. So that's really all we have. Those are the main trials to know about. And with this, we take away that norepinephrine should probably be used as a first-line vasopressor for patients with cardiogenic shock. Moving on to inotrope therapy. So again, these are completely different than vasopressors. They do kind of the opposite. While they both have inotrope effects and increased contractility, these drugs are obviously unique in that they also reduce afterload through peripheral vasodilation. There's a few choices that we have. Unfortunately, in North America, we only have 2. We have dobutamine and milrinone, and in Europe, we have calcium sensitizers, levosimendan, and there's also other phosphodiesterase inhibitors. There's amrinone, but in Canada, we have 2 choices. So when I was preparing for this study, I was scrolling through PubMed. I stumbled along this small study in a minor journal comparing milrinone to dobutamine. All jokes aside, this is a landmark trial in the field done by the group here, led by Dr. Matthew, and I'm very proud of this accomplishment for the group. But I won't spend too much time on this. But of course, when dobutamine was compared to milrinone in all comers with cardiogenic shock, there was no difference in the primary composite outcome and no difference in in-hospital mortality. And we take away from that in all comer, of course, these are different medications and there's some nuances, but certainly in all comers with shock, there seems to be no difference between these two medications in major outcomes. I do wanted to speak a little bit about these other medications that are available and some of the research around them that exist in Europe. Levosimendan has been studied in randomized trials. They're very small. The only real one to know about is this very small trial of 32 patients. It's purely hypothesis generating, and it should be a signal towards future research. But when levosimendan, which is a calcium sensitizer, was compared to enoximone, which is a phosphodiesterase 3 inhibitor, just like milrinone, people who received levosimendan seemed to do better. And again, hypothesis generating, but still interesting. And Dr. Matthew and her group with Shannon Fernando published this meta-analysis in the Canadian Journal of Anesthesia a couple of years ago, looking at all of the data that we have to date in terms of inotrope choice. And this was after the DORI-ME trial came out. And if you look at levosimendan, really it's only in the pre-shock population here at the top that there's some degree of evidence that it might be better than placebo. In the actual SKY C and D cardiogenic shock population with more advanced hypoperfusion, we don't have enough evidence to say for sure if one's better than the other. And as you saw, that's because the trials were very small. So at that time, we actually didn't know a lot about inotropes. We still don't know a lot about them. But I'll touch on the ongoing trial right now briefly, and I'll explain. It's called DORI-ME 2. I won't spend a lot of time on it, but I'll just explain the rationale and what led to its creation and initiation. When DORI-ME was released by the group, some of the criticism that they got was that they're comparing two therapies to each other without actually knowing for sure if either of them improve outcomes in this population. So the thought is, do we know for sure that inotropes improve outcomes in cardiogenic shock? And even more concerning, is there a chance that they might cause harm in this population? And what led to this hypothesis really is some of the heart failure literature that does suggest that there's some harm associated with inotrope use in the decompensated, acute decompensated heart failure population. The OPTIME trial is really the biggest trial that compared milrinone to placebo in heart failure patients, and they saw increased arrhythmias, increased hypotension. Now, mind you, they started at a fairly high dose. Everyone got 0.5 micrograms per kilogram per minute, and they escalated even sometimes to 1.0. So it was a very high dose of milrinone, and it doesn't say anything definitively, but there's this signal of increased harm. In the ADHERE registry, which is observational research, a massive registry of tens of thousands of patients, patients with inotropes seem to die more commonly than patients that received vasodilators like nitro on the ward. Again, it's retrospective, and there may be bias in that patients who were sicker got inotropes and were more likely to die. So again, there's this signal towards worse outcomes in the heart failure population, but I think we can't say anything with certainty for sure based on this evidence. But that led to the design of the DORI-ME 2 trial, which I was very lucky to be a part of. It's led by Dr. Matthew, and it's, the team, her team here at the Heart Institute has done an amazing job of carrying this through. They've randomized hundreds of patients to the point that it's actually nearing the finish line is in sight. And I'm very proud of the group here and Dr. Matthew's group that's carried this through. And I'm just going to touch on it briefly, but the DORI-ME 2 trial is examining the efficacy and safety of inotrope therapy versus placebo in the initial resuscitation of patients with cardiogenic shock. So the way it works is 346 patients will be randomized to either inotrope therapy or placebo therapy. That's done in a blinded fashion. So the placebo is normal saline at a matched rate. And the inotrope is up to the clinician. They can choose either dobutamine or milrinone. And the inclusion criteria, including adult patients with SKY C or D cardiogenic shock, which is the development of hypoperfusion as a consequence of their shock. And these are the exclusion criteria. So patients that are pregnant, out of hospital cardiac arrest, which is a completely different population, patients that can't provide consent, patients that have heart disease that we think is probably doesn't actually do well with inotrope therapy, such as hypertrophic cardiomyopathy obstruction or other LVOT obstruction, severe mitral stenosis, etc., and those that have received inotrope therapy recently. And the infusion runs for a maximum of 12 hours. So actually, the longest time that the study period can be is 12 hours. And if a primary endpoint, which I'll discuss after that, is reached before the 12 hours are over, the study period is terminated, the intervention period is terminated, and the clinician makes a decision about what to continue the patient on. And that could be continue the blinded medication without knowing what it is. It could be open label inotrope therapy. It could be no inotrope therapy, but it's up to the clinician, and the study intervention period is over at that time. And patients are followed until discharge or death. And the last thing I want to say, these are the endpoints. So our primary outcome is a composite of in-hospital death plus all of these things that happen within the 12 hours. And excuse me, these are all the things that would actually cause the study intervention period to be over. And for the patient to go either open label or whatever the clinician wants. And that's sustained hypotension with escalating doses of vasopressors, failure to clear lactate, which we know is a very poor prognostic marker from prior research that we've done, specifically a lactate greater than 3.5 at 6 hours, need for MCS, resuscitated cardiac arrest, and emergent electrical cardioversion. So that is the quick introduction, bringing everyone up to speed on medical therapy. I'm going to keep going just because there's other things I wanted to talk about, but I'm happy to answer questions about that at the end. So moving on to these exciting new areas of research in the field of cardiogenic shock, I'll start with this paper. This is a review paper written by Dr. Matthew, and honestly, like everything's written by Dr. Matthew, so you can just assume that when I talk about things that they're written by her. But it's a very exciting paper that kind of goes over everything that we know up until that point in terms of what to look for from perfusion targets when we're managing these patients with shock. And that's both from an evidence perspective and simply a standard of care perspective, because there's not evidence for everything. So I urge everyone to read this paper because it's quite awesome, and it has the best or my favorite picture of any paper, because it kind of, this is exactly what someone with cardiogenic shock looks like. They usually sit there with their hands crossed like that, and it's just a perfect representation of shock. So these are what I'm going to talk about: blood pressure targets, renal replacement therapy, sedation strategies, and transfusion targets. I'm not picking these because there's a lot of data in the cardiogenic shock population. I chose them because there's a lot of data in the critical care population, and I think they're very interesting areas of research, future research for cardiogenic shock. And that they really get you thinking about what we can do for these patients. So I'll start with blood pressure targets. In Dr. Matthews' review paper that I just mentioned, she outlines all of the blood pressure target guidelines that we have to date from every single guideline body, of which there are none. There's literally no blood pressure guidelines in any of these major guideline bodies and documents to guide management. So we really have no idea how to titrate our vasopressors. We kind of just choose a mean arterial pressure target, but there's no real data to back that up. And I wanted to discuss, again, all the evidence in the critical care population that we have, and how can we possibly apply that to the cardiogenic shock population. So the biggest trial to know probably is the CEPSPAM trial. This is patients, almost 800 patients with septic shock. It's about 10 years old, and it randomized patients to either a low MAP target, 65 to 70, or a high MAP target, 80 to 85. And it was a negative trial, but there's some interesting outcomes to highlight. So again, way more atrial fibrillation in the high target group. That's not surprising. They're going to get more beta-adrenergic stimulation, typically from norepinephrine or another medication like that, and their risk of AFib goes up with more beta-adrenergic activity. The other thing that's very important in this trial is that when they did a subgroup analysis looking at patients with chronic hypertension, the patients with chronic hypertension had a way lower rate of renal replacement therapy. And again, that tells us to personalize these targets, and we have to move away from, this is a trend in all of critical care actually, is moving away from binary treatment plans and personalizing our treatment plan to the patient in front of us. MAP targets is a perfect example. So we don't just flip on Levophed every time someone has a MAP of 63 and turn it off every time someone has a MAP of 66. We actually personalize our blood pressure targets to each patient. This is a great example of that. Everyone should know about the BOX trial. This is an incredibly impressive 2x2 factorial trial of almost 800 patients with out-of-hospital cardiac arrest. And they were randomized to a low target group, 63, or a high target group, 77. And this was a truly negative trial, including all the secondary outcomes, no difference in the primary outcome of death or poor neurological outcome between the two targets. But again, what's different in cardiogenic shock? Because cardiogenic shock is actually really different physiologically than all these other critically ill patients, and we have to kind of treat them differently and think about them differently. So, you know, in the shock population, there are some important harms and benefits to think about. What's the harms associated with cranking up someone's blood pressure? Well, clearly, a lot of this is going to be through alpha agonism, and you're going to increase afterload with peripheral vasoconstriction. The heart might have to work a bit harder. Myocardial oxygen demand might go up a little bit. These are important things to think about. What are the benefits? So, you know, RAIN perfusion, cerebral perfusion pressure is kind of linearly linked to mean arterial pressure to a certain extent. You might increase brain perfusion with a higher MAP target. Certainly, augmenting diastolic blood pressure, everyone knows, will augment coronary perfusion pressure, which is important in the acute MI population. There might reduce the supply-demand mismatch and the myocardial injury, but of course that's balanced against this risk of high afterload and high myocardial oxygen demand. Renal perfusion is huge. As I said, especially in the hypertensive patients, you know, as I'm going to talk about next, all we want to do in a shock patient that's cold and wet is make them diurese. That's kind of the most important thing, and decongest them. So if we can increase the MAP target and they start diuresing, well, that's amazing. And then lastly, how do these patients die? A lot of the time, a lot of them die from gut hyperperfusion. And could changing the blood pressure target improve gut hypoperfusion? Possibly. Could it also worsen gut perfusion by causing peripheral vasoconstriction and decreased oxygen delivery? Also possibly. We'll never know until we actually study this in a randomized fashion. And I wanted to highlight this study that was done by our group, which I was lucky enough to be a part of, taking the Doremi population and dividing those patients into a group of patients that had an average mean arterial pressure of less than 70 versus an average mean arterial pressure of at least 70, splitting them up and seeing how they did. Not a surprise. I'm not expecting anyone to be surprised by the fact that patients that had a higher blood pressure did better. That easily could just be because less critically ill patients were able to generate a higher blood pressure and of course then did better. But as you can see here, patients with a higher mean arterial pressure had better outcomes, and this is simply a signal for this is sort of desperate for a randomized trial. It's screaming out to be studied in a randomized fashion. And when we published this in the European Heart Journal Acute Cardiovascular Care subjournal, there was a really nice editorial by Dr. Bogarts and Amelut, just commenting on the work that we did and then really highlighting the need for a randomized trial, which was nice to read. And I've learned recently there actually is a randomized trial studying this in Europe called NorthShock, which is actually comparing a low target of a MAP of 55 to a high target of 65, which I was interested me a lot. I wouldn't have thought that they would go that low, but we'll see what this is randomizing right now. It's very exciting, so we'll see what happens with this. Another big area in the critical care literature that I wanted to comment on is timing of renal replacement therapy. And this has been studied extensively in the critical care population, and the shock population is totally different. So it's interesting to think about this. There's, as I said, about 4 major randomized trials. There's 2 that you should probably know if you're interested in this field. The Akiki trial in the New England Journal came out, I think, about 10 years ago, randomizing 600 patients with severe AKI and critical illness to either a delayed dialysis start strategy or an immediate start strategy. And there's no difference in outcomes, which is a theme in my talk. But patients with immediate dialysis got a lot more dialysis than patients in the delayed group. And this is the START AKI trial is the other one to know. This is an incredibly impressive trial, to be totally honest, because it's a 3,000 patient trial, which is huge for ICU. And it was actually led by the Edmonton critical care group, led by Sean Bagshaw, who's division head of cardiology of critical care, in Edmonton. And they took patients again with critical illness and severe AKI and randomized them to a accelerated dialysis strategy, which is start within 12 hours, or a delayed start, which is dissuade start for 72 hours unless there's an emergency. For instance, hyperkalemia, refractory acidosis, etc. And this was also a negative trial in terms of the primary outcome, but they actually looked at dialysis dependence at 90 days, and the patients in the early start were more likely to be dependent on dialysis at 90 days. So no benefit and potential harm for accelerated dialysis. But again, what's different for the shock population? Because we have to think about this population a bit differently. And anyone that looks after people with shock knows that the most important thing for a lot of these people, the overloaded patients specifically, is to decongest them as soon as possible. And if you decongest them as soon as possible, everything seems to get better, and you steer the ship away from the rough waters into beautiful, clear, sunny waters. If you reduce end-diastolic volume, you will make the stroke volume better. We know that, and their hemodynamics will improve. Similarly, reducing end-diastolic pressure improves coronary perfusion pressure and reduces supply-demand mismatch and ischemia, especially in acute MI-related shock. If someone's teetering on the edge of intubation, reducing their left atrial pressure reduces pulmonary venous pressure, improves pulmonary edema. And then lastly, if you actually reduce central venous pressure in someone that's very overloaded and renal venous hypertension, the kidneys will be better perfused and everything just gets better. So the question is, in this specific population, might more urgent dialysis actually be beneficial? And this is a great paper to read again in the Canadian Journal of Cardiology, led by Dr. Van Diepen and Dr. Bagshaw. They were both involved in START AKI. And they sort of suggested, should we have modifiers for the shock population? And should that modifier really be, the biggest modifier, be diuretic refractory volume overload? And the key here is, yes, in terms of the AEIOUs that we learn in medical school, the classical indications for dialysis, yes, refractory overload is one of them. But I think most people would agree that our threshold for grabbing dialysis is a little bit lower in the shock population. In the septic, typical critical care population, you know, they have to be really in big trouble from volume overload and diuretic refractoriness to start dialysis. In the cardiogenic shock population, the threshold's lower. You know, if you have someone that's totally overloaded and they're circling the drain in shock, and you give them a big dose of Lasix and maybe a non-loop diuretic, and they don't diurese, we all have a very low threshold to reach for CRRT. So again, this is something to think about, and maybe we should think about this population a bit differently than we do the general critical care population. I'll talk about 2 more of these topics briefly, and then I'll move on to our last few topics. I wanted to touch on sedation strategies very briefly. Of these 4 things, this is definitely the one that has the least amount of data, but again, it's just provocative, and I just wanted to get everybody thinking about that. So how do we typically sedate patients in the ICU? Of course, patients typically need to be sedated due to tube intolerance when they have an endotracheal tube in, and when they're critically ill to reduce metabolic demands and allow their body to start to heal. We typically do use propofol as the primary sedation strategy in the ICU population, but there's a lot of people that have concerns about the myocardial depressant effects of propofol in this sick population. Propofol certainly does reduce blood pressure, we know that, and these patients are very hemodynamically tenuous. You know, if you have someone on 3 vasopressors and 1 or 2 inotropes, what do you sedate them with? It's an interesting question. This has been studied, not really in a randomized fashion. There's been a lot of observational research, and this is still a small trial, but it's looking specifically at the cardiogenic shock population, and it's an observational trial comparing propofol to midazolam. And in a retrospective fashion, patients that receive propofol seem to do much better than patients that receive Versed as the primary sedation strategy. And I think that the key takeaway from this is that you have to be aware of bias. People that were more sick might have been more likely to receive Versed, and thus they did worse. So it's, again, a signal of benefit, and it's certainly not anything definitive. There's also questions about volatile anesthetics. These are anesthetics that there are some anesthesia residents in the room, so I won't go into detail because they know way more than me. But these are medications that people are sedated with in the OR, typically as general anesthesia, and you need an anesthesia machine to administer them. But more and more recently, people have been studying the use of these in the critical care unit through the use of a delivery device such as the Anaconda for sedation in the ICU. There's been some randomized trials. This is a very small one. There's a big trial going on right now in Ottawa using volatile anesthetics in the critical care unit. And in this small trial, there was no real difference in outcomes apart from the secondary outcome of time to spontaneous breathing was much shorter with the sevoflurane arm. Our group did this study and published in the Resuscitation Journal, which was another study that was very exciting to be a part of, but it was a meta-analysis specifically looking at cardiac arrest patients and comparing patients that received volatile anesthetics post-cardiac arrest to patients that received conventional sedation. And there, with moderate certainty evidence, there was a trend, or there was a difference in length of time receiving mechanical ventilation, and that was much shorter in the volatile group. So again, a very interesting piece of information. If you have less time on a vent is certainly a good thing. And what if this was demonstrated as well in the shock population? And if you look at cardiogenic shock, there's actually only one study, and it's on ECMO, so it's a bit different. But you know, it's a bit hard to use an ECMO population because their length of stay is not as dependent on sedation. It's kind of dependent on ECMO and cardiac recovery. So it's hard to really take away anything from this population, but there's no difference here in isoflurane versus propofol when you're on ECMO as the primary sedation strategy. And this is the last topic. It's probably the thing I'm most interested in and excited by, and it's a huge topic in the critical care population. And that's, what hemoglobin target do we transfuse at? So remember, this is like the ultimate personalized medicine topic. We don't transfuse everybody with a hemoglobin of 69 and refuse transfusion in everyone with a hemoglobin of 71. We really do personalize this to every patient in front of us. And the data are all over the place. There's been a number of really important trials, at least probably 5 big RCTs, mostly in the neuro population. And I don't have time to go through all of these big RCTs, but these are the 2 that I wanted you to know about in the critical care population. The TRIC trial came from Ottawa. It's 25 years old. It's led by Paul Hebert, who's one of the intensivists in Ottawa. He doesn't work at TOH anymore, and George Wells, who all of you know, Dr. Wells. And they compared 2 different hemoglobin transfusion targets for critically ill patients, 70 and 100, and patients that were transfused at 70 did better. And that kind of led to this thought that maybe hemoglobin of 70 should be our transfusion target. But lots of other populations are very different. For instance, the Sahara trial, which was a very impressive trial led by Dr. English, who's an intensivist down the hall at the Civic, and published in the New England Journal and presented at CCR in Australia recently. compared a target of 80 to 100 in the subarachnoid population. And there is no difference technically in the primary outcome, but there was a serious trend towards better outcomes in the liberal arm, the hemoglobin target of 100 arm. They actually had numerically significantly better neurological outcomes, although I think the p-value is like 0.06 or something like that. And there's way less vasospasm, which is a huge complication. So that really tells you that's a hemoglobin target of 100, and that's very different than 70. So there's a huge range by which people benefit in terms of hemoglobin transfusion. Many of you know this trial led by the group in Hamilton, TRIX3 trial, looking at hemoglobin targets in the surgical population. There was 5,200 high-risk patients going for cardiac surgery. This group is amazing, and that's a very impressive number of patients. But they compared two different targets, 75 and 95 in the ICU. There's no difference in heart outcomes, and there's, of course, way more transfusions in the liberal group. So we're quite sure, this is such a big trial, we're quite sure that in the cardiac surgery population, a hemoglobin target of 75 is probably okay. Many of you know this trial. I somehow missed it because I'm deep in the ICU world, but this came out recently. Two different transfusion targets for patients that received that had a myocardial infarction, a type 1 MI, either a STEMI or a non-STEMI, and anemia. And they compared a restrictive strategy, hemoglobin of 70 to 80, or a liberal hemoglobin target of 100. And again, a huge trend to benefit in the liberal group, almost significant. So the question is, could this be the same in cardiogenic shock? And these data are all over the place. And I think this is screaming and pleading for a randomized trial. And if you look specifically at the cardiac ICU population, there's actually only one paper, and that's led by Jacob Jenser in the Mayo Clinic and Patrick Lawler, looking at RBC transfusion strategies in critically ill cardiac ICU patients, 12,000 of them, observational trial. Splitting patients up, what hemoglobin nadir did they get transfused at? 80, 80 to 100, excuse me, less than 80, 80 to 100, or more than 100. And the findings were that patients who got transfused at a hemoglobin threshold less than 80 seemed to do better than patients that were transfused at a hemoglobin threshold of more than 100. So again, lots of bias to consider in this particular study because it's an observational study, but food for thought. And as I said, the data are all over the place, and it's a very interesting area for future research. So those are the things I want to talk about. I'm going to move on to two last small topics, and then I want to leave some room for questions at the end. But structural intervention in cardiogenic shock, specifically MitraClip. I'm so proud of the structural group here at the Heart Institute because they're doing some amazing work, and I wanted to highlight that quickly for all of you. So to start, we looked at the DORIMI data, and we did a subgroup analysis looking specifically at patients with valvular disease and how they did. And we split patients in the DORIMI trial up to patients with significant valvular disease, which we defined as moderate or greater stenosis or regurgitation, and patients with no valve disease. And there was 115 patients with no valve disease in DORIMI 1, 74 patients with significant valvular disease. They did much worse. The mortality was 50% in patients that had valve disease, and it was actually only 32% in patients that did not have valve disease. And overall in DORIMI 1, just so you guys know, it was about 40% was the in-hospital death. So patients with aortic stenosis did very poorly. There weren't that many of them, but most of them passed away, unfortunately, in hospital. Patients with MR and cardiogenic shock, about 50% mortality. But in the group that received MitraClip in DORIMI, 11 patients in DORIMI 1, just so you guys know, received MitraClip during their shock state, and the mortality is about 23% in that group. So we started thinking, well, I didn't start thinking, people smarter than me started thinking, could intervening on people's valves in shock actually improve outcomes? So this was a lovely meta-analysis that our group did, led by Richard Jung, who's going to be joining the cardiology group as a cardiology fellow soon, or cardiology resident. And we looked at 141 patients, a network meta-analysis with shock and moderate or greater MR, and looked at outcomes. So the mortality in this population was 15%, patients with MR and shock that got MitraClip. And typically, as I said, in observational registry data, mortality seems to be a bit lower, but this is very low. And so that was interesting. Even 90-day mortality, less than 30%. The other thing that was interesting is it seemed to be feasible in that the majority of patients in this population that got MitraClip had good results on their MitraClip and had significant reduction in MR severity. And the only comparison we could do, because it was a single arm study, was comparing people with failed MitraClip to successful MitraClip. And of course, the people that didn't have a good result did worse. But that led to the development of the Capital Minos trial, which, as I said, is led by the structural heart team. And it's a very exciting trial that I'm proud of the people in the group that are carrying this forward. But they're randomizing 144 patients with shock and moderate or greater MR to MitraClip plus medical therapy versus medical therapy alone, following them till discharge from hospital. The inclusion criteria, essentially, again, SCI-C or D shock in adults who can provide consent. They have moderate or greater MR, and they have anatomy that's feasible for MitraClip. If they have degenerative MR, they need to be assessed for surgery, turned down, and then they can be randomized, and everyone with secondary functional MR is eligible. And the primary outcome is a composite of in-hospital all-cause mortality, cardiac transplant, implantation of a durable VAD, or discharge on palliative inotrope therapy. So that's briefly touching on structural intervention. This is the last thing I wanted to talk about, and it's outcomes, which actually might be the most important type of research out of all this research, because a lot of these trials think about survival, and survival is definitely important. Like that's obviously important, but maybe what's more important than survival is meaningful survival and good functional outcome. And I think the things that people care about are, do I go home and do I live independently? Or do I just survive and go to a long-term care home? Do I get readmitted to hospital, and I go through this revolving door of being readmitted 100 times? How long do I survive? Do I survive to discharge and die a month later? These are things that are kind of more important than just survival. And that's what makes outcome research so important. And I think a lot of the people that are heavily involved in outcomes research, Dr. Matthew has done a lot, and a bunch of the Toronto intensivists are really pioneers in this work, Margaret Herridge and some of her colleagues. And I think they actually think about critical care a bit differently, because they look a year down the road. A lot of us in critical care just look to the point of the patient leaving the ICU and high five each other because we got them through the critical illness. But people that really know this data kind of look forward 12 months or even longer. So the Lotus group, the Lotus project, is led by Dr. Fernando in Oshawa. It's CIHR-funded research program looking at outcomes of survivors of critical illness. They've had some really impressive publications, BMJ, JAMA, other papers, which for registry data, non-randomized data, to get all these JAMA and BMJ publications is amazing. This was a study led by our group, led by actually Lee Sterling, who was a cardiology fellow here, looking at long-term outcomes of acute MI-related shock. I'll touch on it briefly. It's already been presented, actually, so I'm just going to touch on it very briefly. But 10,000 patients with cardiogenic shock using ICES data at 135 centers, looking at outcomes over 10 years. And this is the best graph to know. So 30% in-hospital mortality. Pretty typical, as I said, for registry data. It's a bit lower than the randomized data. But if you look at a year down the road, the light blue at the top are people that went home independently and stayed home. The red are people that died. The middle are people that are readmitted or had to go to long-term care. So that's pretty concerning. Again, if you just look at survival, that's the red. So where the red curves, 60% of patients survived or more their initial hospitalization up until a few months afterwards, and maybe 40% have passed away roughly at the 4-month mark. But if you go all the way to a year, a minority of patients actually went home and stayed home, and that's really important for resource utilization and outcomes for these patients. And it's actually a really good piece of data to discuss with families and show families. If you think someone might not do well, they need to know that this is what the data say. Looking at 10-year outcomes, the survival just continues to fall. The average age in this group is 70, roughly. The median age in this registry is about 70. So maybe not that surprising over a 10-year period, but still quite a scary graph to look at. This is a sub-study that our group did as well, that I was part of, looking at resource utilization. And it's interesting, not that everything's about money, but it's just very interesting to know how much resources are we putting into these patients, and also how do we optimize resource utilization. So we looked at these 10,000 patients. We looked at the cost of each of their admissions and the 1-year costs. So just to give you a rough idea, in Ontario, and by the way, this is US dollars, in Ontario, the median 1-year cost for a heart failure admission is about $10,000. That includes the care that they receive in hospital and post-discharge. The median cost for this group was $37,000 US dollars. And the really interesting thing is there's a huge discrepancy, huge variability in cost among this population post-discharge. So if you, in the group that spent the lowest amount of time at home, the median cost was almost $80,000 US dollars. And for patients that were even readmitted once, the median cost was $65,000 US dollars. And there was significant cost after discharge, median of 13,000, but in the users, that's median across the whole population. And the people that were in this lowest home time quartile, the costs after discharge were much higher. And this is how it was split up. You can see in the graph by service users only. Lots of rehabilitation, lots of complex continuing care, and lots of long-term care. So this is what we should be thinking about when we're looking after these patients. If you stratify by revascularization strategy, remember this is acute MI-related shock. Those that got medical therapy seem to have the least amount of resource utilization. Those that had surgery had the most. And then if you look over the past 10 years, not much has changed. So interesting bits of data for us to think about. And that's really the end. I wanted to touch on my personal career plan. I'm going to be spending the next 6 months at the Royal Brompton and Harefield Hospital in London, training specifically at a high volume MCS and cardiogenic shock center, which I leave on a plane in like 2 weeks. So it's a bit scary and exciting, but I'm looking forward to it. I'm doing a Master's of Science in Clinical Epidemiology right now at the University of Edinburgh. And then I'm going to plan to start to build a research base in the field of cardiogenic shock. So these are some of my acknowledgements from a research perspective. These are the people that really have helped me the most: Dr. Rebecca Matthew, Dr. Pietro DeSanto, Dr. Benjamin Hibbard, Dr. Shannon Fernando. And these are the references. I hope you guys can read all of those. But yeah, that's the end. So I'm happy to answer questions.
That was outstanding, Simon, really outstanding. We do need to talk about the clash of acronyms, though, because CS stands for cardiac sarcoidosis. So we'll take some questions from the floor or maybe online as well. Here's Dr. Labanez.
Is that venting shock would have a big impact when they identify these high risk for shock and so they never get into shock. Yeah, those are fantastic questions. So I'll start with the first question. Dr. Labanaz asked about inflammation and shock. I know this is a huge area of research. I know that there's an ongoing trial, the COCA trial, that's specifically looking at steroids in cardiogenic shock. Inflammation is an area of research in many other areas of medicine as well. And steroids have done wonders in the critically ill population. So the short answer to your question is I don't have much to say other than I'm actually very excited and optimistic about steroids and shock. I didn't cover it here because there was only so much I could talk about, but just know that this is coming. There's two big trials. The biggest one is the COCA trial, looking specifically at steroids to reduce the inflammatory response to cardiogenic shock. And I don't have much to say other than I am very excited and optimistic about that area of research in the field. The other question was about pre-shock, and that's a very good question. So there's I do absolutely think that, you know, when you're Sky B is pretty much the heart's struggling. You're tachycardic, you have relative hypotension, but you haven't hypoperfused yet, and you haven't started to damage your organs yet. And Sky B is kind of the perfect time to intervene, as Dr. Lavinas just said, because once you start hypoperfusing your organs, you start to spiral, literally, because what happens is you hypoperfuse your kidneys, and then your kidneys can't diurese, and then you get more overloaded, and your stroke volume goes down, and truly a vicious cycle starts. So before you start hypoperfusing, that is, as Dr. Lavinas just said, the time to intervene. So I think there's two things. One is there actually is a lot of research being done in the Sky B population, looking at therapies, for instance, levosimendan, is being studied to try and avoid shock. So the first thing is we'll see if there are actually any interventions in a dedicated pre-shock population that actually improve outcomes. And if it does, then we'll adopt those strategies. And you have someone with an anterior STEMI and their heart rate is 125 and sinus, but their lactate's still normal, and you start treatment right away, and that could just be an institutionalized protocol. The other thing is just recognition. So education and recognition. I think here people at the Heart Institute are experts at looking after these patients. In other centers, I don't know what the education is like, but people need to know, like, sinus tachycardia at 120 is terrifying in people that have had a heart attack, and you need to that person, you have this window to preventing death if you act right away. So recognition of what a pre-shock state is and education and on how to manage them is probably the most important thing. And I think other than close monitoring, frequent blood work, probably the best thing we have is urgent decongestion. Like someone who's pre-shock and overloaded, the one thing we know we can do is just decongest them as quickly as possible with diuretics. So I think that's the thing to think about. Any other questions?
Any questions online? End of shelf time. Laboratory substance.
Thanks, Dr. Stanek. So that was a question about age of the red blood cells that we're transfusing. So in terms of the trials that I mentioned, no, I didn't come across that. Although that's a very interesting thought. Does the age of the red blood cells matter? I did do a transfusion elective, like a full month of transfusion medicine as part of my critical care training, and I learned a little bit about that. And I know that the age limit or the shelf life has gone down over the past few decades, the more we learn about how important this is, but it's very variable in terms of the type of blood. So the blood bank, for instance, there's tons of patients at the general hospital that have tons of antibodies, and I'm sure you see that in a heart failure or heart transplant population. But clean blood that is compatible with these patients with lots of Antibodies they just keep it longer, and they know that the blood's very rare for these patients, and they tolerate a longer shelf life. So the shelf life's not the same for each pack of blood that's transfused. And they're very aware of that. But I don't actually know about in this research. It's an excellent question, and I'll have to read about it and get back to you.
I wanted to go back to Dr. Labanaz's question about, getting these patients earlier and trying to prevent the progression of shock. Do you have a sense of, you were our chief resident and a resident, do you have a sense of what our current practice is? Are we transferring patients too late, or should we be transferring patients earlier? And what are the barriers to doing that you see?
Excellent question. So if we're specifically talking about patients in Ottawa, at the Heart Institute or the Civic, it's a bit different. But I think your question about are we transferring patients too late from other centers is very, very, is a fantastic question. I mean, I think this goes back to what I was saying about education and recognition. So if you are not used, if you're working in another hospital that doesn't look after cardiac patients, if you're a generalist, that the rural emerge docs are amazing. They literally need to know about every single thing in the human body that could go wrong and be competent to manage all of them. And they do an amazing job. But, if you don't know how bad, for instance, sinus tachycardia is, it's the fact that they call too late sometimes. So, by the time they call, maybe they've been in emerge for a while and it hasn't been recognized yet, and now they have a lactate, and now they're SCI-C, and we bring them over, and that happens fairly often. And it's hard to recognize someone who's pre-shock. If you're not a cardiologist, it's actually very difficult. So I think the answer to your question, are we transferring these people too late? Absolutely. A lot, as Dr. Labanaz said, they progress through from A to E. So we transfer people with SCI-C and D-shock all the time to the Heart Institute. And the unfortunate thing is we're transferring them. Those people were transferred too late. So it's about recognition and education. I'm not sure the best way to do that, but it's an excellent point. Yeah, Dr. G.
Excellent. That's great.
Thanks.
What in terms of research, I think it's a very difficult thing to do cardiogenic shock because of the heterogeneity in the patient population, as well as all the interventions that have been looked at to, describe sort of a multifaceted approach. So how would we study it systematically? What would be, or three top priorities in terms of keep working through this deal?
Yeah, thanks, Dr. Shi. So that's a great question about how to study all these interesting things and move them forward. So, as we move on and do collaborative research as an institution in this field, the question becomes, to be honest, we only have so many patients with cardiogenic shock. There's so much to research. I've talked to this with Dr. DeSanto a few times, but I think one of the things is 2x2 factorial trials. That's one thing, because the box trial is a perfect example of that. They looked at two things with the same population of patients, and it was an amazing trial. So maybe when we all work together and come up with the next shock trial that we're going to lead at the Heart Institute, because I suspect our group will keep, leading these trials, we can all work together and come up with maybe a 2x2 factorial design. Or like the Capital Research Group can come up with some two things that should be studied, and answer two questions with one trial. So I think that's one thing. Interventions, structural interventions and mechanical circulatory support, can't really do a 2x2 factorial trial with those, and that's going to be a completely different population. But I think we always need to be answering a question and take advantage of every opportunity we can. And I think doing these pragmatic 2x2 factorial trials is probably the first thing that jumps to my mind. but it's a provocative question, so I probably need to do some thinking and come up with some more ideas, and I'll get back to you about that.
Just to add, Sharon, that that critical care network that you see quoted is actually historically the first clinical trials network in Canada. They're over 50 years old now, and they actually published a very nice paper about 10 years ago where they talked about their evolution and formation. And I've been pushing Dr. DeSanto to see if he can form a daughter network to the critical trials group called, the ICCU Clinical Trials Network in Canada, but most importantly that he leads it in Canada as well, and he's on it. So that could be part of the answer to the question. So, okay, fantastic presentation, Simon.
Thank you. Thanks, Dr. Lamina. Thank you.